didactic education, speaking to people from a podium as I'm doing now, really has potential to work only at the lowest levels of learning. And so you can add some knowledge and a bit of understanding or comprehension, but if you want people to really apply their knowledge, if you want them to analyze problems and be able to solve problems, if you want people to think critically and be able to combine their knowledge as a team or even as individuals to solve new problems, you need a new paradigm. You need something that's more conducive to that kind of learning. And so we've rediscovered some ideas that have been around in the education literature and education science, that notion that, that learning in adults requires some sort of experience. So adults learn best if you give them an experience and then you allow them to reflect on it. And so having an experience, reflecting on it, using that reflection to conceptualize some ideas, then being able to experiment with those ideas and try similar or new problems again is a paradigm called the adult learning model, and it's being used in healthcare education in this decade. And simulation is one of the centerpieces of allowing that kind of process. Faculty development has changed. I know in our own institution, you can now advance from assistant professor to associate professor, from associate professor to professor, simply on your educational contributions, something that never happened before. We had our first professor named just from education this past year. And so the notion of educating the clinical faculty to truly become educators, to understand the educational process and apply it, is a new idea, and an idea that's taken hold in these 2 decades. And so specific education around simulation, advancing educators. I'm pleased to see some familiar faces in the audience who've attended instructor courses that I've been involved with, one here in Hong Kong back in March. So medical education has changed, and evidence has begun to appear. Evidence that simulation does work, that it does help people work higher up on the learning pyramid. And so at the past meeting of the Society for Simulation in Healthcare, I was privileged to be part of and attend the first Research Consensus Summit. So several hundred people, many of the leaders in the field, got together and analyzed what was the state of the research, what were the gaps in research, and where should we go moving forward in studying simulation. The results of that effort have been quite impressive and will appear in the journal Simulation in Healthcare in the next month or 2. I would urge you to look at it because I think you'll be impressed by how much work has been done to advance the evidence that simulation is a meaningful technique in healthcare. The patient safety movement. So in my opinion, this has been the biggest mover of simulation, the reason that the curve has gone up so steeply. I guess it's the main ingredient. In spite of my gratefulness to Dr. Semmelweis about hand washing, the public awareness of patient safety and the notion that accidents occur in hospitals and that people die due to medical errors and incomplete care is on the forefront in every nation, and so that idea has propelled simulation forward. This video I want to show you is a colleague that may be familiar to some of you. This is Alan Mary. He's a prominent anaesthetist from New Zealand. This is a video of him participating in a simulation course. I'm showing you this video with his permission, in fact, his encouragement. Alan is one of the world's foremost experts on medical error. He's actually, his major interest is on medication error. And here you're going to see Alan not acting, spontaneously make a medication error and discover it in the middle of the case.
Excuse me, I think we're getting a hypertensive response. Well, we need to check the blood. Can I have a pair of hands? Can I have a pair of hands here, please?
What kind of hands would you like?
Someone to help me, please. Just someone to help me. I'm not sure if she's vomiting or not. I need to give her some epidural. She's just become a bit hypertensive with the top up.
Yeah.
I don't feel like I'm just going to give you some epidural. Where's the dispatch? I'm just going to give you something.
You're doing great. Just try to relax, okay?
So that's that's 100 mics of. I guess that's the net, but I've just given the wrong drug actually.
He just made the error and he just realized it.
Well, she came in with 31.5. Okay, and maybe we can.
So I would expect to build a pulse rate increase and a blood pressure increase, and we'll just make sure you're getting oxygen. It'll probably be quite good. It'll probably affect your thing. So, just so as you know, I've just given her a small dose of epinephrine by mistake. I thought it was ephedrine. Okay. It's 100 mics, so I think she'll actually be quite a good treatment of the hypertension. It wasn't what I intended.
Okay.
So Alan accidentally gave the wrong drug. His immediate reaction was, oh, well, maybe that drug will be better for her than the one I intended to give. And he couldn't believe he explained it that way because he was really quite mortified that he picked up the wrong syringe and gave the wrong drug. I think simulation's ability to capture medical errors, to study, to talk about medical errors without actually harming a patient is its number one benefit. And I think it's the thing that propels simulation and has propelled simulation forward. The other notion is that financial models are beginning to appear that will fund simulation in the future. And I think we'll hear about some of them in this meeting. So we have a maternity teamwork and crisis management course.
No. All right. No. What happened? Are you done with it?
I didn't ask for that.
Are you okay?
My first baby. That's my only daughter. That's all I have.
What are you guys talking about?
Well, you know what?
This can't be.
Okay, well.
This can't.
What are you
No.
Okay.
Just put it back. Can you put it back? Can you put it back? Can you fix it?
No.
You're still.
Can you do me a favor, Nancy? Can you take the baby and put him back in the crib? Can we put the baby back in the crib?
So this is a medical error occurring, and the participants in this course are obstetrical staff from our institution, and they're having to deal with this medical error as it's occurring in the presence of the family. And so this kind of course is required in the Harvard system, and all of our obstetrician, labor nurses, midwives, and obstetrical anesthesiologists have to participate in such courses. So these courses are sponsored by our insurance company, our malpractice insurance company, who is interested in reducing the rate of bad outcomes for which they get sued in obstetrics. And so they have actuarial data looking at what the rates of accidents, claims, dollars paid out before simulation and after simulation and various other patient safety-related activities. And they've shown a substantial drop in bad outcomes. And so they've used these data to offer money back into the system to pay for simulation. And so anesthesiologists, obstetricians, surgeons all get substantial malpractice premium discounts. These are very large dollar amounts because their malpractice premiums are so high. And this coming year, emergency medicine will join in and be given an insurance premium discount, the exact amount of which has yet to be determined. So this is a financial model. There are other financial models out there. Specialty groups are beginning to require simulation training. I know in America, In surgery, there are various requirements to do fundamentals of laparoscopic surgery. They're going to be introducing, they tell me, this coming year, teamwork training in surgery as a required subject. Anesthesiologists, for maintenance of certification, have to undergo this training and have to pay for it. I think we'll see workforce development as a driver for this kind of education for simulation, and Mark Cormack will be speaking later in the conference about that. And the idea of shortening training, of making training more efficient and capturing the dollars from it is being discussed. So that leaves us to what will happen. So all these ingredients came to pass. We've seen this upswing in simulation. I believe it'll continue, but it's contingent on you all doing several things. So one is to continue to innovate. There are lots of gaps. There are lots of opportunities for new ideas in simulation. There's so much we could learn about using this technique that is untapped. And so the community needs to continue to be innovative. We need new champions. You're the champions. We represent a very small fraction of the healthcare workforce, and yet the passion of this group and groups like you around the world are the ones who are going to have to push this forward. The technology will improve. We need to work with our industrial colleagues in order to make those innovations happen, to let them know what we really need, to come up with ideas to make them happen. And if we embrace those technologies, they will come to serve us. We need to develop faculty into true medical educators. Just because you went to medical school or nursing school doesn't make you a good educator, and so we need to spend our efforts teaching people how to teach. We need to continue to build evidence. There's, in the summit report, you'll see it's full of gaps. It's full of areas that have yet to be tested. It needs a lot of repetition. There are very few studies that have ever been repeated. And so good science, repeat studies, fills in the gaps, and that world is in front of us. We really continue to need to focus on patient safety. I believe that that's the main attribute of simulation that will carry it forward. And finally, we need to press for financial models that break the status quo, that change us from the Osler-Flexner model of the residency into new paradigms that support new ways of learning, and those financial models will advance simulation as that happens. So, so I guess I'm supposed to think about way into the future. I don't know what's going to happen. Here's me as an old man. And I guess in my vision of this, I wind up working for the dummies. So on that rather sick video, I think I'll complete my talk. And I don't know, Adam, Katie, do we have time for any questions? We do. Thank you. I don't know if we have microphones, but does anyone have any questions? I won't bite.